All right, Pediatric Emergencies Part 2, picking up where we left off, altered mental status. So sudden illness and medical emergencies section that we're in. So not many illnesses occur suddenly in young children. Most of this is something that has taken some time. So it's important to recognize and then treat these key pediatric illnesses. So altered mental status, they have some different causes: low blood glucose level, poisoning, post-seizure state, infection, head trauma, decreased oxygen levels, lots of reasons. So what we'll do for that, complete a patient assessment, paying particular attention to any clues at the scene. So we want to pay attention to their vital signs. We want to make sure that we're rechecking their vital signs to monitor any changes. Try our best to calm them and calm the family as well, and then be prepared to support any of those ABCs as needed. And in the event you do have an unconscious person, we're going to place them in that recovery position that we've talked about and practiced. And then moving on to respiratory illnesses. So what we're talking about, respiratory problem range from anything from a minor cold to a complete blockage of the airway. Now, because infants breathe primarily through their noses, just a minor cold can cause breathing difficulties for these infants. So as EMRs, we need to be able to recognize 3 serious conditions. And what we're going to talk about is asthma, croup, and then epiglottitis. So asthma, a child who has asthma, they're already usually being treated for it. They're taking a prescribed medication. What it is asthma is caused by a spasm or a constriction, bronchoconstriction, and inflammation of the smaller airways in the lungs. And that's what we're talking about, that bronchoconstriction. So spasm or constriction and inflammation of the smaller airways. And what that does is it produces a really kind of a characteristic wheeze sound. So a child who's experiencing an asthma attack, they're going to be in a lot of obvious respiratory distress. I shouldn't say a lot. It could just be beginning, and they're not in that obvious respiratory distress. But it's going to we're going to notice, and we're going to hear things. So primary treatment consists of calming, reassuring. We want to calm and reassure both the parents and the child involved. So we want to put them in a position to make breathing more comfortable for them. As you see, this guy is doing this pursed lip breathing. The body kind of starts doing that on its own. But what it does is it builds up all of this pressure because they're blowing through a tight, like a small opening, and it's creating back pressure, which causes the airways to actually open up. So that purseless breathing relieves some of the internal lung pressure that can cause an asthma attack. Now, if the child has asthma meds, has an asthma medication, but it's not been administered, we want to help the parent administer the med. If child's physician is not available, if that's how they do things, as they call their doctor or whatever, you're probably going to need to go ahead and move on and get them to the hospital. So we want to make sure that we are making good choices for these guys, because this is something that can end up developing into that respiratory distress, respiratory failure, all of that we talked about. So croup, when we talked about asthma, remember we talked about asthma versus croup versus epiglottitis. So croup, it's an infection of the upper airway that occurs mainly in children who are between 6 months and 6 years. So what happens is the lower throat swells and it compresses the airway. We get a different sound. We get a hoarse, kind of a whooping noise during inhalation, and then that seal-like barking cough. Unless you've heard that won't mean a lot to you. If you've heard a kid with croup, that seal-like barking cough, that you see those words, it will mean a lot to you because it sounds just like that. So you'll know when you hear that. Croup happens to occur a lot more often in colder climates, and it's frequently accompanied by a cold. Now, lack of fright and willingness to lie down are important signs that distinguish croup from epiglottitis. When we talk about epiglottitis, it's going to be very different than croup, but sometimes they can be confused with one another. So if the EMS unit is delayed, ask parents to turn on the hot water in the shower. Many times you'll respond to these patients, and they may be in the shower with mom or dad, just sitting there while the water runs, and they're outside, sitting on the sink or on the toilet. and allowing that moisturized air to help things. That moist, warm air actually helps to relax the vocal cords, and it kind of lessens that yucky, seal-like bark cough. It helps that croupy noise. It helps to lessen that. Now, epiglottitis. It is a severe inflammation of the epiglottis. If you remember, that epiglottis is that small flap that covers the trachea during swallowing. So you can see how this could be a real problem, because that is where things are happening. That's kind of the money end of things, That flap, that epiglottis, becomes so inflamed and swollen that air movement into the trachea, it's almost completely blocked. So epiglottitis usually occurs in children between ages 3 and 6. Signs and symptoms, things we may or may not see. Usually sitting upright. You're going to see positioning going to be very positional and not willing to lay down and do those things, because like we said, you could see a lot of spit and drool and everything, and next thing you know, they're breathing that in. The body takes care of itself. It's not going to allow that to happen. So they can't swallow. They're not coughing. The child is drooling. They're anxious and frightened. Their chin is thrust forward. So they have a lot of these compensatory mechanisms that are going on to make things better. So one of the things we can do is to make them as comfortable as possible, and as you see listed, with as little handling as possible. Do not make these children mad, anxious, upset, or anything. Do not look in their airway. Do not do anything. If you think that there may be a chance they have epiglottitis, we just take them to the hospital. If you need to maybe give them oxygen, then I wouldn't probably put a mask on them unless you had to. I just do some blow-by, like just have their mom or dad or you hold it, or they can hold it right in front of their face, just a cannula to where they're getting enough of that oxygen in. But be thoughtful about what you do. You get them a little bit wound up and it can make their airway worse. So moving on to drowning. Drowning is caused by submersion in the water and initially causes respiratory arrest. So it is the second most common cause of accidental death among children 5 years of age or younger in the United States. So ordinary water sources around the home, those increase the risk of drowning for young children. So, pools and that type of stuff. If you respond to a drowning situation, do not put yourself in danger if you choose to attempt a rescue. So you want to be thoughtful about the way you're getting someone. Typically in a pool, not going to be a problem. In a river, fast-moving water, that could be a creek, that could be a real problem. So signs and symptoms of drowning, obviously lack of breathing, no pulse, all of that stuff. We want to get in and look at the ABCs, get them on their side, onto one side, and allow water to drain out of their mouth. Use a suction if it's available. Start rescue breathing in the event that you need to. Get some O2, no pulse, start some chest compressions. Now, if there is a chance that they have a cervical spine injury, you'll need to stabilize the neck. And then to reduce the risk of hypothermia, dry the child with towels. If you're talking about Oklahoma summer, not typically worrying about hypothermia, but we're not always talking about that. So cover the child with dry blankets or even jackets. Get them in a warm unit in the event you have that available. Then heat-related illness. It can range from relatively minor muscle cramps to vomiting, heat exhaustion, and then all the way up to heat stroke. So heat stroke's serious, potentially fatal condition. It requires rapid treatment. So we want to make sure we remove their clothing. We want to sponge water over them, fan them. So, we're doing all of our best just to cool them down. You can wrap them in some wet sheets to speed up the evaporation and then cooling process, but we don't want to let them become chilled, because that just kind of makes us even in a worse spot. So fevers, high fever. I know we're covering a lot of things, so we're just kind of touching on all of these little pieces. Fevers are common in children. They can be caused by lots and lots of different infections, but ear infections are very common, maybe even GI, gastrointestinal infections. But because temperature regulating mechanism in these young kids hasn't fully developed, that a very high temperature can occur quickly. So most children, though, they can tolerate temps as high as 104 when we're talking about high fevers. What we're going to do about that, though, we want to uncover the child so their body heat can escape. So many times these kids, they're wrapped up in 4 blankets and they got the little pants on and all that stuff. We want to get all that off so that heat can get out of there. And we want to reduce the high temperature by undressing them. We want to fan them to cool them down And then we want to make sure we protect them in the event that there's a seizure or something like that. Now, we mentioned seizures. Let's talk about that. So seizures can result from a high fever. They also can have epilepsy. So it could be something that they have an issue with, or it could just be a one-time febrile seizures. These seizures can vary in intensity, so it can be a simple kind of momentary staring spell, all the way up to a generalized seizure that involves full body tremors. So typically seizures aren't usually dangerous, but during that seizure, the child loses consciousness, their eyes roll back, their teeth become clenched, body shakes, has some severe jerking movements. Now, we can see some of the things we could see is a child's skin. It can become pale or turn blue. Sometimes they may lose bladder and bowel control, not uncommon at all. As you might think about, I think I mentioned it before, you run on an adult or even, an adolescent and they've had in bladder incontinence, that might be a real problem because they're probably going to be very embarrassed because it's something completely out of their control, but, it's something you may need to deal with. So place a patient on a floor or a bed to prevent injury. We're talking about if they're having a seizure, and then maintain an adequate airway after the seizure ends, not while it's going on, because you might have some real problems with those teeth. So pay attention to that. O2, tropic transport, ABCs, all that stuff. After it's over, cool the patient if they have a fever. Talking about those kids. Now, vomiting and diarrhea, usually caused by gastrointestinal infections. So prolonged vomiting and diarrhea, that's kind of what we're talking about. That can produce some severe dehydration. Typically when you see that dehydrated child, they're going to be lethargic. They're also going to have very dry skin. So hospitalization may be required to replace those fluids through an IV. But if you suspect a child may be dehydrated, we make sure we get an ambulance. They may need to go to the hospital. Abdominal pain, one of the most serious causes of abdominal pain in children, we're talking about children, is appendicitis. So it's often seen in people who are between 10 and 25. Cramping pain in the belly button area moves to the right lower quadrant of the abdomen, becoming steady and more severe. And usually that child is going to be nauseated, not have any appetite, might could or could not vomit. So we want to, treat every child with a sore or tender abdomen as an emergency. They need to probably be seen. Okay, so poisoning. Poisoning, young children, obviously they're curious. They often like to sample things. They want to touch things and taste things and swallow things and all that, especially contents of brightly colored bottles or even cans. Two of the most common types of poisonings in children are those caused by ingestion and absorption. So ingestion, we're talking about, ingested poison, it's taken by mouth. So a child who has ingested a poison may have the following signs and symptoms: chemical burns and odors, nausea, vomiting, a lot of the same stuff that we've talked about when we talked about poisonings with adults. Abdominal pain, diarrhea. Whoops, what did I do here? Wrong button, I guess. Here we go. So later symptoms, abnormal or decreased respirations, maybe unconsciousness, seizures. So if you believe a child has ingested a poisonous substance, then we need to take some steps. So we want to try to identify the poison. We want to send the bottle or the container along with the child to the emergency department, and then try to gather any spilled tablets and replace them in the bottle so they can be counted so we can understand what was taken. We want to get poison control on board with us. May need to give the child large amounts of water or administer activated charcoal. We're going to want to monitor their breathing and pulse. A lot of this depends upon what poison control wants us to do or what your local protocols are. And now absorption. That occurs when a poisonous substance enters the body through the skin. So we talked about ingestion and now absorption. So a child who's absorbed a poison, they may have localized symptoms, so skin irritation or even burning, systemic signs and symptoms, so nausea, vomiting, dizziness, shock. So if you believe a child has absorbed a poisonous substance, got a couple of things we probably want to think about. So we want to ensure that they're no longer in contact with that substance. We want to protect ourselves from that exposure. We want to remove their clothing if we think their clothing is contaminated, brush off any dry chemical, wash off anything, and then try to identify what it is. We want to make sure we're monitoring these children for, A, B's, and C's again. If they vomited, if in the event you're able to, that might not be a horrible idea to kind of collect some of that to show the ER. And then going into SIDS. So SIDS, condition frequently mistaken for child abuse, is SIDS. It's also called crib death. So sudden and unexpected death of an apparently healthy infant. Usually occurs in infants between the ages of 3 weeks and 7 months. And what's weird is there's really no adequate scientific explanation exists for SIDS. There's been a lot of kind of hypothesis. A lot of people thinking if you leave them on one side, or if they're on their back, or if they're on their belly, and all these different things. I'm not, who knows what it is, but I don't. From everything I've seen, there is no scientific explanation that tells us, yes or no, that this is a particular reason. So if they're warm, we're going to begin CPR, and many times, for the times that I've been around this, they have not been. So it's not something that you're doing on scene. You're not working these kids. Many times these infants have been dead for several hours. Their body is cold and lifeless, unfortunately. Now, do not mistake those large bruise-like blotches on their body for signs of child abuse. What happens is you get this lividity, and the blood will actually pool in the areas of the infant, after death, and it can appear to be bruising, but make sure that other people are looking at that kind of stuff. We're not going to assume that there was child abuse involved, but we are going to get other people involved. Be compassionate, supportive. This is a horrible situation to be in for you, and obviously for mom and dad. My gosh. Pediatric trauma. So number one killer of children. We kind of took a bad turn, didn't we? SIDS, and now talking about trauma, killing babies. So we're going to treat an injured child as you would an injured adult, but we are going to remember those differences. So some of those differences, these children, many times are not going to be able to communicate as well as an adult can. So they may or may not be able to communicate the symptoms. They might be shy and overwhelmed by having an adult right in their face and, working on them and asking them questions and all of that. So you may need to adapt your materials and equipment and all of that to child size, where you have a board for a 6-foot adult and now you have, a 2.5-foot kid. That could potentially be a problem. So you need to be prepared to kind of evolve your processes, adapt and overcome, essentially, to adapt what you're doing and make some changes in how you're going to take care of this little guy. So a child does not show signs of shock as early as the adult, but they can progress into severe shock quickly. So we talked about that. They don't have those same reserves as adults do. They compensate, and then they're kind of done, and that's what we're saying here. Now, patterns of injury sustained by children will reflect 3 factors. So the type of trauma they experience, the type of activity causing the injury, the child's anatomy. Those are all patterns of injury. So the motor vehicle crashes, also another thing. Unrestrained patients tend to have more head and neck injuries. And then restrained patients, they often suffer head, spinal, and abdominal injuries. And then bicycle accidents, that's another thing. So children often suffer head, spinal, abdominal, extremity injuries in bicycle accidents. So, use of bicycle helmets, they can help reduce the number and severity of head injuries as well. Now, when children hit by cars, so pedestrians often sustain chest, abdominal, thigh, and head injuries. When we're talking about continuing on about these patterns of injury, falls from a height or diving accidents, they tend to cause head and spinal injury, and obviously extremity injuries as well. And then burns, they can be a major cause of injuries to children as well. Now, in that picture, you see these are typical injuries when a child's been hit by a motor vehicle. So we may see, we talked a little bit about it, but the head, abdomen, chest, leg from the bumper, just depends upon where the energy is transferred to, meaning like kind of where they were hit, So sports activities, they can cause a wide variety of injuries depending on the type of sports activity. So treatment regardless of the cause of injury. We want to check ABCs. We want to stop any bleeding. We want to treat them for shock. We want to get that full body secondary assessment if we have time to. We want to stabilize all the injuries that we can find if you have time. If the patient has head lacerations, treat wounds with direct pressure and then use the appropriate bandaging techniques that we've talked about. Now, traumatic shock in children. So children show shock symptoms much more slowly than adults, but as we've mentioned multiple times, they do progress through those stages of shock quickly. So if signs of shock are present, the child is already in severe shock. What I mean by that, cool, clammy skin, rapid, weak pulse, rapid or shallow respirations. All right, sorry, I just got a phone call. So let's finish up traumatic shock in children. Seizures, relatively common in children who have sustained a head injury. So those greatest dangers that patients who sustain trauma are going to be airway obstruction and hemorrhage. So when we think about caring for an injured child, open and maintain our airway. We want to control the bleeding. Of course, we want to arrange for prompt transport. So get them where they need to go is what we're saying. Car seats. If you find a child properly restrained in a car seat after a motor vehicle crash, leave them in the car seat until the ambulance arrives. So most of the time you can transport these kids in their car seat in the ambulance. So unless you have protocols that says otherwise, just leave them in there because they've been protected. They have C-spine protection for the most part, all of that. Now, child abuse. So not limited to any ethnic, social, economic group. It's obviously for everybody, not even, particular level of education. There's no limiting factors. So suspect abuse if the child's injuries don't match the story that you're told about how the injuries occurred. An abused child, they can have many visible injuries at different, and one of the key things is that at different stages of healing. So if that child is withdrawn or fearful or hostile, unwilling to discuss, then that's something that should probably raise a little bit of concern for you. And we want to treat their injuries. And if you're suspicious that they might involve child abuse, then make sure, first thing we're going to do is ensure the safety of the child before we move on to the next thing of the reporting and all of that. So signs and symptoms, multiple fractures, bruises in various stages of healing. You might see some bites or burns or bizarre accidents that don't really seem like they make sense that caused some injuries. So here's some bruises at different ages, suggesting physical maltreatment. I'll let you look at those in your book. And then transport child to an appropriate medical facility. So if the parents object to having them examined by a physician, make sure we get law enforcement personnel and explain your concerns to them. Neglect is another form of child abuse. So children who are neglected, often dirty or too thin, or maybe appear developmentally delayed because of a lack of stimulation. Signs and symptoms of that neglect, lack of adult supervision, malnourished, unsafe and untreated, and all of that. All of these things we need to handle with, care and get other people involved, as well as sexual assault. So in addition to experiencing sexual assault, the child could have been beaten and have other serious injuries. So if you do suspect sexual assault, then obtain as much information as possible from the child and any witnesses. Make sure that we're providing a caring approach. It's going to be important, and take appropriate action and shield the child from onlookers. So we've talked about privacy and all of that. And all the victims of sexual assault, they should receive transport to an appropriate medical facility. Debriefing. We've mentioned this before, but with kids, it can get a little bit rough. So you're going to respond to many calls that involve children. And, a lot of times these calls can produce strong emotional reactions. So you may feel, especially angry or helpless or, whatever when you suspect neglect or abuse of a child. So you may need to talk about that, talk about some of those frustrations, talk about that within your own department or whoever you work with. There may be some things that you need to talk about, learn some coping strategies, and learn some ways to burn off some energy and all of that stuff. So, all right, summary. I'm not going to cover much summary. I'm going to let you guys here. I'll put it right here. We'll just hit these. You have the time to pause it and read it because my brain's done. So we're talking about number 3, always going to be airway, ventilate, any respiratory problems. So remember, respiratory causes cardiac problems with these kids. Heimlich maneuver going to be important to remember that when you come to your BLS day. Respiratory distress requires immediate attention. Remember these. So when we talk about asthma, croup, and epiglottitis, that being the most serious. And our last two, SIDS and poisonings, and then trauma. That's it, guys and gals. That is pediatrics. That's a wrap. So until we see you in the next one.